Without further ado, I'm pleased to introduce to you our Canna Talk team.
Good morning, good afternoon, depending on where you are. It is my pleasure to welcome and to introduce Ethan Russo, who is a board certified neurologist, psychopharmacology researcher, and author. He's the founder and CEO of Credo Science and serves on the scientific advisory board of the American Botanical Council. He previously served as Director of Research and Development of the International Cannabis and Cannabinoids Institute, Medical Director of Phytex, a biotechnology company researching and developing innovative approaches targeting the human endocannabinoid system. And from 2003 to 2014, he served as Senior Medical Advisor, Medical Monitor, and Study Physician for GW Pharmaceuticals, for numerous clinical trials on Sativex and Epidiolex. A clinical neurologist for 20 years, he had a practice with a strong chronic pain component. And in 1995, Dr. Russo pursued a 3-month sabbatical pursuing ethnobotanical research with the Machiganga in Parque Nacional de Manu, Peru. He is the past president of the International Cannabinoid Research Society and former chairman of the International Association of Cannabinoid Medicines. He's the author of numerous scientific papers, books, and was founding editor of the Journal of Cannabis Therapeutics. If I continued, we would use up all of our time. So without further ado, I am pleased to welcome the author of our educational module on clinical endocannabinoid deficiency syndromes, Dr. Ethan Russo.
Thanks,
Ethan, welcome. Thank you for joining us.
Welcome, Dr. Russo. Yes, this is Janester Wilson King speaking. And one thing we wanted to do today is Dr. Frye and I will cut our questions short so that we can get in more of the audience questions. So please send your write your questions in the chat so we can get them, get to them and try to get as many of your questions answered as possible. I'm going to start with, what is the theory and hypothesis of clinical endocannabinoid deficiency conditions? Who gets it and why, Dr. Russo?
Sure. Well, as a neurologist, I was struck by the idea that particularly as we age, there are a variety of problems that arise that seem tied to deficiencies of neurotransmitters. So while it's oversimplistic, we know that in dementia, particularly Alzheimer's disease, there's a deficiency of acetylcholine, the memory neurotransmitter. Mm-hmm. In Parkinson's disease, there is a deficiency of dopamine function. In depression, although it's more complex and is an inflammatory disease tied to lack of neuroplasticity, it's been implicated that there are deficiencies of serotonin. So many years ago, probably about in the late 90s, I thought, what would a deficiency of endocannabinoid function look like? What diseases would it produce? And we knew certain things. Because the endocannabinoid system modulates pain, pain would likely be a feature if there were a deficiency. But it also affects mood. So depression and anxiety would likely feature in it as well. And I started thinking about what disorders might be related to this, and 3 came to mind. And they were migraine, fibromyalgia, and irritable bowel syndrome. And as I really dug in to the pathophysiology of these disorders, it seemed that they had a number of things in common, particularly that they were hyperalgesic states. That's a way of saying that there's pain in a situation where there's no obvious tissue injury, and it seems out of proportion, at least to male doctors seeing patients with these things. And this has led to the mistaken notion that these are psychosomatic disorders. Well, more than 100 years ago, the neurologist Sigmund Freud established psychoanalysis basically because he thought all these disorders were biochemical in nature, but they didn't have the technology to ascertain them. Well, the same is still true to a limited extent, but we're getting to the point where we can help prove these things. Additionally, fibromyalgia, migraine, and irritable bowel syndrome are what are known as comorbid conditions, meaning that frequently, unfortunately, people may have manifestations of 1, 2, or 3. And often over the course of a lifetime, someone may develop one of these additional conditions where they only had one before. So this is a problem. Now, often these are implicated as being genetic in origin, and there may be tendencies that way, but it's clear that a lot of people who are healthy develop one or more of these. Again, they're supposed to be lifelong conditions, but certainly people go into remission from them, especially if they have an appropriate intervention. Unfortunately, that intervention is often a conventional medicine that doesn't work very well. And this is another reason to think that these probably had an underlying explanation that hadn't been addressed yet by conventional pharmaceuticals. And what better place to look than the one thing that people with these conditions tend to use and find more effective, and that's cannabis. So cannabis, and especially THC, seemingly would be replacing something that was deficient in the body of people who harbored these conditions. So that was the idea. And I presented this first in a section of a book, Handbook of Psychotropic Herbs in 2001. Then expounded on it in 2004 in an article giving more detail about it, again addressed in 2016 in a subsequent article re-examining what had happened in the ensuing 12 years, which was a lot. During that time and subsequently, there's been a lot of scientific investigation that tends to support the idea that there can be endocannabinoid deficiencies tied to these and a variety of other conditions, including post-traumatic stress, autism, you name it. So that was the idea. There are still detractors out there, but the theory has been cited in the literature many hundreds of times, either as a passing thought or to indicate support for it. So I'm pleased that it's brought attention to these conditions and different ways of thinking about them rather than saying that they're psychiatric in origin, which is clearly false.
Yes, yes, true. Thank you so much for that. Just one follow-up, Dr. Frye, if you don't mind. Um, when you mentioned that they are diseases that often aren't treated very well with conventional medication and get labeled as mental health illnesses, especially maybe by male physicians, it made me think of several GYN conditions and how they get labeled. The patients get labeled with mental health illnesses and seem to be hysterical and all that sort of thing. Does this occur mostly in women? Clinical endocannabinoid deficiency conditions?
Sure, particularly fibromyalgia and migraine have a female predilection. Now, some of that is skewed because guys aren't always ready to go to the doctor for a pain condition, but epidemiologically, it's clear that women are more susceptible.
Mhm.
That makes one wonder why. Well, we
Right.
certainly know of hormonal triggers in migraine. Those are less apparent in these other conditions. But it may really have pertinence to differences in immune function in men and women. And particularly, I'm going to take a tangent here and mention that these conditions seem to be more prevalent than they had been in the past. So we need to, again, to query why. And one of the obvious explanations would be differences in diet. And the modern American diet is very pro-inflammatory. as opposed to the anti-inflammatory profile of diets in the past. And we have a notable dearth of fermented foods in the modern diet as compared to in the past. And the microbiome, the bacteria in the gut, have a very strong relationship to endocannabinoid function. And it seems to me, and increasingly to other people, that treating the microbiome in a way that's more helpful to it seems to improve these conditions, and certainly would be one of the recommended approaches to their treatment.
You know, you would think that even with autoimmune illnesses that where there's a female uh, predilection, that there is some element of endocannabinoid deficiency. You know, there are a lot of things that impact the development of autoimmune, like environmental, certainly diet and other toxins that we're exposed to. But you mentioned this, the fermentation, and you had done your work in Peru. Would you share a little bit about what that experience was like and what you learned from that research?
Yeah, so I spent almost 3 months in Peru in the Amazon working with the Machigenga tribe. And this is a group of people that had broken off from a bigger settlement because they wanted to live a traditional lifestyle, and they were avoiding the missionaries in another village. And basically, their pharmacy was the rainforest. And in the course of that time, my research partner, Glenn Shepard, and I collected something along the lines of 500 medicinal plants that they used to good advantage. In general, they were very healthy. Their biggest problems were for Western infectious diseases, basically things that were introduced from outside to which they didn't have immunity. But one of the features of their diet was that it would be very anti-inflammatory in general. But in particular, they made a drink, a fermented manioc or yucca root, Manihot esculenta. So this is a starchy root. They fermented this to make a drink that the Machigenga called oberoki. And it probably was reminiscent of dilute yogurt in terms of its taste. We know that this likely contains some mixture of lactobacilli, as well as some kinds of yeast. So it'd be probably similar to water kefir. But this kind of drink, low in alcohol, they did use it socially. Sometimes people would overdo, but that would be 10 cups of the stuff rather than 1 or 2. But this may well have had a lot to do with their general health. So that's something that could bear additional investigation.
It certainly sounds like that addressing this underlying inflammatory process, as well as toning that endocannabinoid system, go hand in hand. And certainly I would expect that we would get better results by addressing both the microbiome as well as replenishing or augmenting endocannabinoid function. Very good.
Yes, and that leads into your discussion of prebiotics in your module. I found it very interesting and very informative. You talked about how prebiotics reduce infectious diarrhea, alleviate irritable bowel disease, inflammatory bowel disease, reduce colon cancer risk, and actually even decrease obesity. Can you tell the audience what are prebiotics and what is the mechanism of action in which they can do all those things?
Sure, happy to. First, let's discuss probiotics. So probiotics would be things like yogurt or lacto-fermented vegetables that supply good bacteria to the gut. And they have a lot of the effects you mentioned, boosting immunity, preserving the gut mucosa, helping prevent leaky gut, irritable bowel, inflammatory bowel diseases, etc. So these good bacteria make a lot of things that we need. They produce vitamins. Gut bacteria, the source for most of the serotonin in the body. They're just intimately related to all kinds of functions, including our well-being in general. In other words, our mental state. And this has clearly been demonstrated. Prebiotics are foods that we normally don't digest, but are the feedstock for the bacteria. So the probiotic bacteria eat the prebiotics. And this includes some things that are familiar, like the Lyaceae. This would be your onions, garlic, leeks, vegetables of that sort, but also some less familiar items like burdock root, which is a great prebiotic, or acacia fiber, which comes from the sap of an African tree. And the probiotic bacteria really eat that up. And these are things that can easily be incorporated into the diet, either as supplements or powders that are added to whatever food.
I might also throw in that dandelion greens and bananas are pretty good insoluble fibers that support our microbiome as well. Easy to find.
Bet.
All right, so it's interesting that we have this concept of endocannabinoid deficiency, but you don't see a lot of studies looking at actual endocannabinoid function, let's say like in anandamide levels. I know that there are a few in the autism studies looking at anandamide levels that are significantly lower when compared to neurotypicals. Do you have any thoughts about why we don't do that more with some of these other conditions like fibromyalgia and migraines and irritable bowel?
Yeah, there are multiple explanations. One is these studies are very difficult to do. So we have circulating endocannabinoid levels, and they may or may not reflect what's going on in the brain. Unfortunately, serum levels of endocannabinoids are very labile. If you take a blood sample, there are enzymes that'll break down that material very, very quickly. So to study serum levels of endocannabinoids, you have to take the material, spin it down, and put it under liquid nitrogen, and then get it to a specialty lab that can analyze it. So your friendly neighborhood lab can't do this. Only certain centers can. That's one. Second, what we really need is non-invasive methods of judging endocannabinoid tone or levels in the brain. Previously, this hasn't been available, but more recently, it has become possible with PET scans, positron emission tomography, to assess CB1 function in the brain. Now, the hooker here is that each study costs $10,000. And you need numbers to prove differences between a study population with a disorder and people who don't have it. And, if you want 10 of each, you're already looking at 200K just for that part of the study. We need more of this for sure, but right now it's both difficult and expensive to investigate.
Very interesting. Thank you. I'm going to start taking a few audience questions so I can keep my word and have us not take up so much of the time. The first is from Bonnie Goldstein. Hey, Bonnie. She says, hello and thank you for your tremendous contributions to endocannabinoid medicine. Her question is, do you think it is possible that COVID long haulers may have endocannabinoid deficiency and that medical cannabis may help?
Yeah. Oh, I'm sorry, keep going.
Sorry. No, go ahead. Go ahead.
Now, I was going to say that, it's a really intriguing possibility, and it would be a great thing to investigate. Um, an obvious place to look is what features of cannabis or what components could address long haul COVID symptoms. And certainly fatigue and difficulty thinking would be among them. There certainly would be a place for low dose THC to feel better and affect the mood, maybe treat the anxiety. You wouldn't want to overdo it there. Getting endocannabinoid tone increased, probably CBD could help with that. With any memory or mental fog, it'd be great to have some alpha pinene, which is an acetylcholinesterase inhibitor. That may help. I'd be interested in hearing more from long haul COVID patients about what their experience has been. I have not seen any specific studies yet. Hopefully we will. Yeah, it's an intriguing possibility.
Yeah,
Maybe
sure.
Bonnie.
With the symptoms that, sorry.
No, I was.
No, I was just going to say with oh, I'll just throw this out here that a lot of the symptoms with long haulers almost mimic some of the symptoms we see with some other post-infectious syndromes like pandas and Lyme, and you wonder if this isn't still a residual immune system gone amok that's still secreting, too much tumor necrotic factor or interferon gamma, where some of these cannabinoids might help balance that pro/anti-inflammatory response.
Yeah, that's a great explanation. So another thing I'd certainly recommend to anybody doing this is something I recommend to everyone, which is again, pursuing the probiotics and prebiotics. That's going to solve a lot of problems, and it might well help with long COVID.
Absolutely. Here's another audience question. Could endocannabinoid deficiency be passed to children born after the condition develops in women?
Again, there may be certain genetic factors. We know that there's certain genes tied to migraine, certain genes tied to IBS, but I don't think genetics are the only explanation. Another thing about families is you not only get your genes from your family, you get your diet from your family, at least while you're a child. And especially in a situation where we're beset by junk food and other pro-inflammatory foods and processed foods. I think most American children are getting a really bad start in terms of their nutrition and what the ravages will be on their body as a result of it.
I agree. And also it's the microbiome is established pretty much in the first 3 years. And so things that promote, we not only share our diet, but we share our germs too. So the child is inoculated with the microbiome of the mother from passing through the vagina, from skin to skin contact, from breastfeeding. And when those mechanisms are disrupted, we're sort of setting up these children to have issues further down, but certainly that diet plays a big part. There's so many additives and emulsifiers and processed foods that actually disrupt the microbiome. So these things are so important in trying to prevent these long-term chronic conditions.
Certainly.
You want to pick an audience question now, Patricia, or do you want me to go ahead?
Oh, well, you're doing a good job, so you go ahead.
Well, thank you for the compliment.
You're welcome.
Here's another audience question. Can you address Frye insufficiency, endocannabinoid tone, and obesity? I think maybe you touched on some of that already, but not specifically Frye.
Sure. So fatty acid aminohydrolase is the enzyme that breaks down anandamide. So there are various substances, many synthetics are being pursued to slow down that breakdown of anandamide, but there are issues. Firstly, Fa works on a variety of substrates besides anandamide, so we're always worried about off-target effects. My answer to all those synthetic drugs is, why not use cannabidiol? Because one of its mechanisms of action is to inhibit the breakdown of anandamide by Fa, and thus it increases endocannabinoid tone, and that likely doesn't require huge doses. The relation to obesity is complex. Again, this comes into the microbiome. There have been two sort of archetypes of what people who use cannabis look like. And one would be the obese slacker stoner. But in fact, the true stereotype is the skinny hippie. And this is because despite the phenomenon of the munchies associated with THC, people who use cannabis regularly tend to be leaner than people who don't. And this is likely, again, mediated through the microbiome. Clooney et al. Did a study on this, and it's clear that THC alters the microbiome balance in a positive direction in terms of lowering the risk of obesity, which in turn leads to metabolic syndrome, type 2 diabetes, etc. Again, think of the skinny hippie on why he or she looks that way.
Mm-hmm.
And there's some rodent studies that have looked at the caloric intake, like with diet and induced obesity, and those rodents that are pre-treated with cannabinoids, particularly THC, actually don't gain as much weight. And so that there is probably some direct effect on calorie expenditure, as well as glucose metabolism, which affects insulin levels. So it's all really interconnected.
Quite right.
Mm-hmm. Absolutely. What do you think is the best way to approach clinical research of cannabis when the traditional pharmaceutical model operates with single molecule drugs?
Well, what I'd like to point out is a couple of things. First of all, prior to 75 years ago, medicine was plant medicine, and it remains the case for indigenous populations around the world. A lot of this is really, I hate to say it, but a function of capitalist approaches, meaning that a drug company is invested in patenting a molecule that they invented. And the model is to design it so that it will bind to a receptor with the highest potency and affinity, and they worry about toxicological problems later. So this is why so many drugs get FDA approved and then get yanked from the market when
Mm-hmm.
greater number of consumers start using them, and we figure out that they're bad for the liver or bone marrow or anything else. In contrast, with plants, we can assume that there's a lower inherent toxicity. Now, obviously, there are poisons in some plants, but often it's a matter of dose. You can regard cannabis as a poison if you overdo it as well. But it is a situation in which there's a greater likelihood that your liver and your body in general is going to metabolize a plant-based medicine with fewer problems. Again, there are always exceptions. I don't want to be categorical about this. But many of us, when we have a condition, are going to think of a botanical treatment first before resorting to the big guns. Now, in the case of a bacterial infection, it's probably better to go with an antibiotic. But again, fortunately, we have choices and we're learning more about which are the better and safer ones.
Absolutely. Absolutely. Um, in your module, you discussed other disorders of clinical endocannabinoid deficiency, and you included hyperemesis gravidarum. Now, that's certainly a condition in which cannabis has shown to be very effective, even in low and very low doses, whereas the traditional pharmaceutical line has been mostly ineffective. Would you explain why you included hyperemesis as a clinical endocannabinoid deficiency disease,
Yeah,
please?
well, it was a hypothesis. Now, there was a study that looked at serum levels of endocannabinoids and didn't find a relationship. But again, I would then question, what are the brain levels? However, we have this thing called ethics committees or institutional review boards. If you come to them with a study saying, okay, we have these pregnant ladies with hyperemesis gravidarum and we want to do a lumbar puncture on each of them to see what the endocannabinoid levels are in the cerebrospinal fluid, they're not likely to say yes. I would hesitate to even ask, but at some point, hopefully we have non-invasive and cheaper scans that could look at this. But, certainly the inclusion, I thought, um, was the reason I thought it could be related was, again, because of the exquisite sensitivity. Women with this condition seem to have to cannabis treatment, whereas standard antiemetics just don't do the job very well. And this is why we have so many women who are celebrities um, having publicity when they end up in the hospital during pregnancy. Um, so now the good thing is everybody is THC phobic. I like to point out that in the 19th century, obstetrics and gynecology were among the main reasons or the leading indications for cannabis treatment. And that's certainly not true today because of this THC phobia. However, it may be that other substances in cannabis, such as THCA and CBDA, may be quite beneficial in hyperemesis gravidarum. We need to see. The beauty there is tiny doses would be necessary. Additionally, this is hopefully not a condition that is present throughout pregnancy. The danger of brief intervention is nil. Particularly compared to the dangers of hospitalization, costs of hospitalization, and the use of drugs that don't work and are clearly more toxic than cannabinoids are. So it's a situation where I really think we need to investigate this further.
Absolutely. It's
Ethan, you
very,
brought up CBDA. Any thoughts about CBDA or of the I know I've used THCA with seizure disorder, but what about CBDA? Do you have any thoughts about CBDA and seizures?
Yeah, it's a strange one. What we know about the pharmacology of CBDA is that it is profoundly active at serotonin 1A receptor, between 100 and 1,000 times more potent than CBD. We do know that drugs with this profile have an antiemetic effect, and clearly CBD has an antiemetic effect. CBDA should be active at a much tinier dose. It is clearly in rodents. It really hasn't been systematically investigated in people, but I bet Bonnie has had good luck with it, and I bet Dustin has had good luck with it. And it may be there actually are mechanisms by which these serotonin 1A drugs like CBD and CBDA could have anticonvulsant effects as well. Now, again, practitioners who have used it have found CBDA as a useful adjunct in people with epilepsy that were not otherwise controlled. And certainly it's worthy of investigation because, again, the doses are tiny, and it's non-toxic, and a really reasonable thing to investigate.
Yeah, I've used it quite a bit for inflammation and for even with kids with autism where there's a lot of neuroinflammation. But I wasn't aware of the 5-HT1A activity. So that may explain why it is very helpful in those kids with a lot of irritability and anxiety.
Sure.
Bonnie says there's an article that came out in January entitled CBDA Exhibits Entourage-like Improvements of Anticonvulsant Activity in an Acute Rat Model of Seizures. So there's an article, January of this year.
Sure.
Okay. Could you also weigh in on Delta 8?
Oh boy. Okay, first some background. Delta 8 is a natural component of cannabis. With modern equipment, high performance liquid chromatography, a good lab can separate Delta 8 and Delta 9. Now, usually there's a lot more Delta 9 than Delta 8. And we're not sure what the differences are. It may be that Delta 8 is slightly less potent than Delta 9. It is more shelf stable than Delta 9. Delta 8 should have most of the features of Delta 9. Was used in a study by Abrahamoff et al. In the 90s in Israel as a very effective anti-nausea agent in children with cancer who are being treated with chemotherapy. So that's a good part. The bad part is there are many companies in this country now which are purveying the illusion that Delta 8 made from transmogrification of CBD is a legal product that they can sell at will. It is not legal. And there are many lawyers who will disagree with me, but they think that it's legal under the hemp bill that was passed about 2018. But that doesn't supersede what's in the Controlled Substances Act of 1970, which basically says that hemp isn't illegal, but once you go extracting things and dickering with it biochemically, that's all illegal. Additionally, Delta 8 is an isomer of Delta 9. There was a 1986 law, the Analogs Act, that Congress passed that basically said, if you make something that closely resembles a substance that's Schedule 1 and illegal, then your new thing is illegal too. Although they don't have the resources to do it and they're otherwise occupied, if the FDA or the DEA decided to clamp down tomorrow on this Delta 8 commerce, they certainly could. Plus, if that weren't enough, I'm on a panel with a variety of experts. I was on a panel recently with a fellow who runs a very, very large lab in Canada. And he's looked at some of these Delta 8 products, and he has never seen one that wasn't contaminated with other stuff. And this included Delta 6 THC, Delta 10 THC. We know even less about them. And maybe they're safe, but it's also equally possible that they have some innate toxicity. Given the lack of quality control in the industry, I don't know that I could recommend that anybody use these products. And again, nobody should think that they're legal.
I agree.
Yes, I agree. And I'm glad you said that more than once. They are not legal. A lot of people
And
are
we don't know a lot. Yeah. And with the poor regulation of how these products are produced and what's in them, it's just another Another problem
Yes.
to
Um,
consider.
just to also give you some added information, Bonnie says that she's found CBDA to reduce seizures in some patients who did not have success with other cannabinoids to treat their seizures. That's really important. And
Again,
Dr. Joe D says CBDA also has some anti-neoplastic applications.
yeah, it's something, again, I hypothesized about. People downplay the evidence from the past, but if we look at what the Renaissance herbalists did with cannabis or hemp at that time, uh, they recommended it willy-nilly for tumors and other growths that likely were benign. Um, and usually this was raw hemp. So what's in raw hemp? Raw hemp has CBDA. This is something, well, I've been trying to study for a long time. We need to look at CBDA more closely in relation to tumors. Absolutely.
Yes.
Absolutely.
Ethan, there's a question here that I want to, it's from my friend Min, who wants to know, what are your thoughts on adenosine receptor blockers to minimize the adverse effects of cannabis? I suppose that's related to THC.
Yeah, there's a complex relationship between the adenosine receptors and cannabis components. Um, THC, CBD, and limonene all affect the A2A receptor. But I've got to say at this point, I really can't shed a lot more light on this. But it's clear that the endocannabinoid system is intimately related with neurotransmitters in general. And so it's an area that needs more work, and certainly I need more education myself on what the relationships might be.
Yeah.
That was from one of my Farm D friends. So,
Yeah, I wish I knew better.
okay.
um, Ethan, this is from Dr. Benson Hausman. Uh, Besides the study from Barron et al. In 2018, do you know of others working on identifying chemovars for specific ailments? That is trying to, move away from the single compound, single effect paradigm that seems to be plaguing the medical cannabis world, and that is the pharmaceutical world.
Yeah. Well, part of the problem is that kind of research is almost impossible to do in this country because we're enjoined from using material that's available in dispensaries or even the black market. Rather, it all has to come from NIDA, and that material is not representative of what cannabis is and can be. Um, so, um, again, if we look at part of the problem is there are various meta-analyses that are done that try and show which conditions are best treated, but they lump everything together. So it means herbal cannabis, it means Sativex, and I think every preparation has to be judged on its contents. And this is why I always emphasize that I think that one of the changes we need in policy is that it should be possible to have a certificate of analysis on a current batch of material for every cannabis-based product that's sold in this country, and whether it's over the internet or in a dispensary. Again, there are detractors that feel that there is no entourage effect or synergy of ingredients, but I beg to differ. We have plenty of evidence that there is. And clearly millions of consumers that find differences in cannabis chemovars one to another can't be all wrong.
Right.
Um, um, so yeah, again, I have strong opinions about how the components work together. But until we have the freedom to really investigate this more systematically, we're going to be left with these questions.
Yeah. Well, there's they're giving out these DEA licenses such that you cultivate cannabis and process it and uh, create products that are to be sold only for research. And I believe Sue Sisley got one. A gentleman here in Miami, Florida, got one as well. And maybe it's a start to it's a start to see whole plant chemovars and their effects on various conditions and research. At least we're going to be using what people are, hopefully the DEA licensees are creating what people are purchasing from the dispensaries so that we can get more information. So that might be something to look forward to.
Yeah, I hope so, but I'm not that optimistic.
I can understand that. That's for sure.
I heard that song before. Yeah. So you want to just, this is not really with endocannabinoid syndrome, deficiency syndrome, but while we have you here and talking a little bit about different cannabinoids, CBG is starting to blossom everywhere, and it certainly seems to be quite effective, especially when combined with CBD. Any thoughts on CBG and neuroexcitability, inflammation,
Yeah.
other endocannabinoid deficiency syndrome
Well, I think
symptoms?
cannabigerol is the next big thing. So I'm glad you asked. With my colleagues, Carrie Cutler and Michelle Sexton, we have an article that's we hope will be released soon. It's under revision. I need to get the corrections or suggestions back this weekend. But basically, we did a survey. There's a great deal of CBG in the northwest part of the US at this time. And so we wanted to look, because nobody has, at what people were using it for. So we got 127 people who were using CBG preparations that were at least 50% cannabigerol, okay? Not trace amounts like you'll find in many types of cannabis. The results were really amazing. People reported really excellent efficacy for pain, sleep, anxiety in particular. Also inflammatory bowel disease, which was a bit of a surprise because there's only been one report on an animal study related to that. But beyond that, people reported a very benign adverse event profile. There were very few associated side effects. Nobody reported any withdrawal effects when they'd used it and then stopped. But I think there's tremendous potential here. Just mention a couple of conditions, particularly anxiety. CBG has, it seems, an ability to help people compartmentalize anxiety, just put it aside for a while. And this is without sedation or any evidence of dependency that would be associated with most anti-anxiety drugs. The other super promising area is treatment for prostate cancer and metastatic prostate cancer, because we know that CBG is a TRPM8 antagonist, and that's a target receptor expressed in prostate cancer.
Yeah, according to Joe D, CBG has anti-neoplastic applications even wider than CBDA.
Yeah, one other, I hate the idea, I almost left this out. CBG is really an excellent antibiotic as well.
Yes.
It's active against a broad range of gram-positive organisms, and particularly MRSA, so methicillin-resistant Staph aureus, and VRE, vancomycin-resistant Enterococcus. Plus, recent research has demonstrated it will also work against gram-negatives when it's combined with conventional agents that have lost their effect. So there'll be a lot more literature coming out soon in relation to the antibiotic efficacy of CBG.
Nice.
Excellent.
Does it have effects for, is it effective for Parkinson's as well? In a
Uh,
way?
I've only heard anecdotes, again, no systematic investigation, but I've heard that people have been having success with it. Parkinson's is a really tough nut to crack. It's a very widespread, the effects are widespread and complicated. It's really unclear what the best preparations are. And again, it's a situation where the acid cannabinoids may be as or more effective than the neutral cannabinoids. We need more work.
Yes. Need more research. Famous last words. Yes. More.
Yeah.
We've got
All right.
about 3 minutes left.
Any-
Do we have time for a few question or two, or do we want to wrap it up?
Let's do one more question.
Okay. How do you feel, Ethan?
I'm still here.
Okay. That's good. That's good to hear. All right. How about another question? Let's see.
Let's see. Well, okay, this is a question about drug interaction with, let's say, other cannabinoids, but I'll read the question. What are your thoughts on drug interactions, especially with CBD? Would there be a time when you would say not to use, let's say, with someone's blood pressure medicine?
Not as likely there. Immunotherapy for cancer seems to be the place that most experts don't want to have cannabis-based intervention. CBD only has significant drug-drug interactions at higher doses, and the most notable example would be in epilepsy treatment with polypharmacy. But, for example, interactions with valproic acid, which is a bad actor, it just doesn't play well with other drugs. But particularly with clobazam and Dravet syndrome, CBD at high doses will interfere, will lead to buildup of a metabolite, N-desmethylclobazam, which is highly sedating. But the solution isn't to get rid of the CBD, it is to lower the clobazam dose. So yeah, there are cytochrome P450 interactions. My honest assessment is that these are overly hyped to the extent of trying to get people not to use CBD at all. Yeah, it can be a problem, but usually of elevated doses and in the face of polypharmacy.
I would like to add that the patients I see are usually on multiple medications, and that the CBD doses, that are under 30 milligrams, I'm not that concerned about. If they get up a little higher than that, and that's kind of an arbitrary number, then I have them space CBD apart by a couple of hours from medications that I'd be more concerned about, let's say like warfarin or a statin, where there's a narrow therapeutic window. But in the patients I see that come in with a laundry list of medications, I have not, except for immunotherapy and cancer, I have not said no to CBD or any other cannabinoid, really.
Well, it seems wise to me.
Yeah, for sure. Okay, we are up against the time now. There were several questions on cannabinoid hyperemesis syndrome, and that I did not touch on, but I wanted to let you all know that Dr. Russo will be conducting Journal Club next month on that very subject. He has a recent paper that's just been published, and he will talk about that. So you can save those questions for that, okay?
Yeah, I would just point out that the
Mm-hmm.
article's available open source. Probably the easiest place is if you go to ethanrusso.org and hit the tab for library, you'll see it right there. And the study as well as the appendices that have all the questionnaire results are there, and those are free. They can be disseminated without copyright issues because it is open source.
All right, excellent.
Thank you.